To help physicians appreciate the challenges of laboratory testing, Thermo Fisher Scientific has created a series of short videos in the Next Step series, utilizing noted experts to better aid physicians' understanding of laboratory testing. This series focuses on demystifying appropriate molecular testing in common but complex disease states in clinical oncology, including lung, breast, and GI cancers. Your host, Dr. Anagh Vora, is Head of Medical Affairs and the Global Medical Director in Immuno-Oncology and Molecular Diagnostics at Thermo Fisher Scientific CSD. Dr. Vora currently directs institutional and physician education. He has lectured extensively at medical schools in the U.S. and Europe, including Harvard, Stanford, and the Karolinska Institute on the application and appropriate utilization of laboratory testing in oncology.
I'm Anagh Vora, and as a laboratory physician and clinical pathologist, I understand the difficulty that many of us face in navigating the complexity of laboratory testing, especially with newer technologies such as next-generation sequencing or the latest clinical biomarkers. But if not ordered in the right sequence or used in the correct clinical scenario, even older tests can be confusing.
Mutation testing in cancer. The right treatment starts with the right test. In this video, we will discuss the clinical implications of mutational testing in cancer by answering 4 key questions. What is the role of mutation testing in cancer? Which set of mutations should we really test for? Should we test locally or send out for molecular testing? Which laboratory? Which test? Does it matter?
Since the initial mapping of the human genome, clinical research and experience has demonstrated the molecular basis of cancer. Today, sequencing technology is able to identify various mutations at a deep level in minute quantities from surgical tissue, needle core, or FNA biopsies, and even in blood and other body fluids. However, the ability to sequence DNA at this level does not always equal the ability to understand or predict clinical outcomes that truly impact patient care. The goal of this video is to give you a quick and practical guide on identifying the specific genes and variants recommended for testing, based on established guidelines and expert opinion, as well as how to select the most appropriate methodology to test for these mutations. Remember, the right treatment starts with the right test.
What is the role of mutation testing in cancer?
Currently, mutation testing in cancer consists of a trial and error approach, where single genes are tested individually, looking for one mutation at a time. However, this does not give a detailed picture of the mutation status of the patient up front when the diagnosis is made. This approach also increases the time for actionable results and guidance before first-line therapy, since each mutation is assessed separately. Single-gene testing also uses up the limited tissue that is available during each test. Therefore, the need for rebiopsy is increased in these patients in order to obtain more tissue, in some cases dramatically, with associated costs and potential complications, all with limited success in identifying additional targets. Next-generation sequencing, or NGS, has the ability to sequence several to literally thousands of genes simultaneously from one sample. As physicians, we need to understand the flood of information that can be generated does not always translate to clinical relevance for our patients. In fact, large NGS panels with extensive gene lists actually pose a clinical dilemma and added responsibility for the ordering physician, especially since we do not currently know the actionability or impact of all the variants identified. Testing with large gene panels do not necessarily change patient management and usually raise more questions than answers.
Which set of mutations should we really test for in advanced non-small cell lung cancer? All, some, or one at a time?
Many clinicians recommend taking a middle approach between single gene testing and large NGS panels, utilizing limited NGS panels that focus on mutations with evidence-based clinical actionability, in which mutation testing would have specific diagnostic, predictive, or therapeutic implications for our patients. This approach allows the clinician to harness the power of NGS with its greater sensitivity and the identification of new abnormalities which would not routinely be detected with older methodologies. The advantages of limited NGS panels include more complete mutational characterization up front compared to sequential gene testing, mutation testing that's focused on actionable genes with demonstrable clinical impact, unnecessary superfluous or clinically irrelevant data which the clinician must now decipher, more efficient use of limited tissue, shorter turnaround time, decreased rebiopsy rates with their added expense and associated complications, and most importantly, guidance to the clinician in choosing the specific or combination therapies that are most appropriate for our patients and excluding those that are probably ineffective. Consequently, we support the recommended guidelines for EGFR and ALK genomic testing in all patients, with further inclusion of additional mutations, preferably at the time of diagnosis, to allow the appropriate selection of first-line and subsequent therapies. Remember, larger gene lists are not necessarily better. Choosing a limited gene panel that focuses on clinical actionability is a more practical solution in identifying first-line therapies for our patients. Additional testing can always be performed as necessary if the limited panel is negative. We can test this strategy ourselves by simply observing how often the extensive panels lead to change in treatment compared to the limited panels. In the majority of cases, the same actionable mutations are identified in both panels. In one study, comparing a 50-gene panel versus a 343-gene panel, researchers were able to demonstrate that in 99% of the cases, the same mutations were picked up by the smaller panel, leading to appropriate therapy. When in doubt, it's always a good idea to talk to your local pathologist to determine which type of testing is necessary. They can walk you through the complexities and clinical actionability of genomic testing and interpretation.
Should we test locally or send out for molecular testing? Dr. Guy DeCibio is an associate professor of pathology at California North State University College of Medicine and specializes in surgical and molecular pathology. Prior to CNU, Dr. DeCibio was research associate at the Human Genome Mapping Center at UCSF and Stanford.
Hi, I'm Guy DeCibio. Cancer testing, especially molecular testing, can be complicated and fraught with potential errors, so it's understandable that many of us send samples to high-volume or molecular laboratories. In fact, there are certain situations when sending out tests may be appropriate, such as lack of molecular or esoteric testing at your institution. However, there are specific benefits of performing molecular testing at your own institution. These include, first and foremost, the ability to have a direct conversation, physician to physician, around the clinical implications of genomic testing. For example, the clinical interpretation of molecular results within the context of other pathologic variables, such as surgical biopsy results, tumor border morphology, and lymph node status, can all be included in such a conversation. This is not always possible with send-out testing, where the overall clinical and genomic interpretation is left to the ordering physician. Secondly, control of the specimen within the host institution ensures that essential quality controls, quality assurance, and legal parameters are all met and are appropriate for the patient's clinical circumstances. With the widespread use of electronic medical ordering, genomic testing can also be ordered at the time of diagnosis as recommended by specialty guidelines, expediting initiation of target-driven therapy. Finally, if NGS testing is not available at your institution, it is suggested that you speak with your local pathologist directly on why this testing is not offered. Sequencing technology has improved dramatically in the last several years with several platforms that are now FDA approved, and the cost of NGS testing has come down precipitously. Irrespective of costs, it is important to remember that molecular testing, such as NGS, can identify multiple targetable mutations simultaneously and is an essential component of modern oncology treatment.
Which laboratory? Which test? Does it matter?
Different testing methods show inherent strengths and weaknesses. In this section, we will quickly summarize the most important aspects and their direct impact on patient care. These include
accuracy of the test.
Most of us take the accuracy of the tests we order for granted. However, with NGS testing, there are pre-analytical factors attributable to DNA quantity and quality. These lead to unacceptable errors, including increased false positives, false negatives, or rejection of samples based on insufficient quantity. Most samples submitted in the clinical setting are limited in quantity, not only in the amount of tissue, but tumor DNA content within the sample. These samples are usually formalin fixed, a process which chemically modifies and fragments the DNA, making it harder to sequence. Hence the importance of selecting an assay that can detect mutations in challenging FFPE samples or very minute levels of cell-free DNA within body fluids.
Sample input quantity and quantity not sufficient rate.
Though these two variables determine how often testing will be successful in our cancer patients, they affect the feasibility of mutational testing in different ways. The sample input quantity is the minimum amount of DNA or RNA expressed in nanograms required to accurately run the assay, and should be sufficiently above the limit of detection in order to decrease potential errors. The quantity not sufficient rate, or QNS, is how often your patient's sample will be rejected based on the testing laboratory's sample requirements before DNA is actually quantified. Both parameters are set by the individual laboratory and reflect the underlying capacity of the methodology and platform utilized within a given laboratory. Laboratories that require increased sample size or utilize platforms that necessitate higher genomic DNA input amounts can reject up to a quarter or 25% of your patient's samples that might have been successfully run if sent to another lab, utilizing a different platform with lower input requirements. Consequently, the methodology and NGS platform chosen by different laboratories dramatically affects our ability to perform mutation testing for our patients.
Clinical relevance.
It's advisable to use mutational testing that has direct clinical relevance for our patients, especially in the selection or avoidance of therapy, rather than mutations that are not clinically actionable. Differences between various gene panels, especially larger panels, are more reflective of the inclusion of ancillary cancer genes or passenger mutations, not specifically linked to therapy. Larger gene panels may appear comprehensive, but it's important to remember they are only indicative of the mutational status at the time of collection, and not the underlying pathology within the patient currently or in the future.
Turnaround time.
Finally, as we all know, time is a crucial parameter in the active management of cancer patients, especially those in late stages, where survival is measured in weeks and months rather than years. An incorrect choice in therapy due to extended turnaround time would undoubtedly result in suboptimal outcomes and/or progression of disease. We should pick tests that provide actionable results linked to selection or avoidance of therapy. Ideally, therapy should commence from sample submission within days rather than weeks. Though larger panels may claim more information after 2 or even 6 weeks, it may not be actionable and possibly cost the patient their health or worse, their life, before the results are even received.
Summary.
Modern molecular testing should accurately identify relevant mutations, but should also be time and tissue efficient, especially with limited patient samples. As we have seen, appropriate selection of focused NGS panels based on actionable mutations is a critical component of modern oncology diagnosis and treatment. Remember, the right treatment starts with the right test.
For more information or to watch additional videos, please visit our website at thermofisherinstitute.com.